Dear colleagues, in partnership with the Société Francophone de Nephrologie, Dialyse et Transplantation, the Österreichische Gesellschaft für Nephrologie and the Deutsche Gesellschaft für Nephrologie, Marcus at Home welcomes Dr. Sebastien Rubin in Bordeaux, with whom we would like to discuss malignant hypertension at the first stage of our Tour Académique 2023. We are thus at least 7 days ahead of the cyclists who start their tour a few hours from now in Bilbao to arrive in Bordeaux on Friday, 7th July. Sebastien, thanks for being our first expert on our way to Paris. Great to have you.
Dear colleagues, I'm Dominique Guerrot from nephrologist in Rouen. I'm very happy to introduce Sebastien Rubin today. Sebastien is a nephrologist in Bordeaux, which you of course all know. He has specific interests in vascular nephropathies related to hypertension, related to diabetes, related to genetic conditions. And his specific focus in hypertension is malignant hypertension. This is the topic he's going to discuss with us today. And he's had the opportunity to work on the Bordeaux cohort of malignant hypertension patients and is one of the leaders in the Hama cohort in France, which studies malignant hypertension and will probably extend to Europe. So, Sebastien, it's our great pleasure to listen to you today. Thanks for being there.
Thank you very much for your invitation. The first tips I want to say that I want to have this question: what is malignant hypertension? So, malignant hypertension is not just severe hypertension. Severe hypertension is hypertensive urgencies. It's not just hypertension requiring urgent treatment. This form of hypertension is hypertension emergencies. Malignant hypertension is characterized by severe hypertension with acute ischemic injury to target organs. It requires immediate medical intervention and an investigation into its underlying cause. So, one distinct aspect of malignant hypertension is its name, this strange name, malignant. This name reflects its prognosis. As you can see here, so on the left side, the mortality rate was very high and close to 100% at 5 years in the 50s. In the right side, we observe a significant improvement in survival, starting from the 80s. These positive trends coincide with the introduction of ACE inhibitors. So in the next slide, you can see the incidence of severe hypertension and malignant hypertension. This incidence increase, particularly in the United States. This increasing incidence can be attributed to various factors, including limited access to healthcare, especially among vulnerable population. Notably, African Americans are disproportionately affected by both conditions, limited access to healthcare and malignant hypertension. So the question is the blood pressure level a good diagnostic criteria for malignant hypertension? The answer is clear, is no. The level of blood pressure alone is not sufficient to diagnose malignant hypertension. It is crucial to understand that the blood pressure level between severe hypertension and malignant hypertension can be very similar, making it challenging or impossible to differentiate between the two based on blood pressure measurement alone. So in the next slide, you can see the classical definition of malignant hypertension. This classical definition is highlighted by the 2018 ESH guideline. Malignant hypertension is a severe hypertension with malignant retinopathy. Here you can see the classical malignant retinopathy, hemorrhage, exudate, and papilledema. But in the next slide, you can see that in reality, malignant hypertension is not, of course, an ocular disease. Malignant hypertension is a systemic disease. This very informative figure is provided by a small clinical study. The main point is that patients with malignant hypertension exhibited involvement of multiple organs, with most patients showed affection in all 3 organs assessed in this study, kidney, brain, and retina. This highlights the systemic natures of malignant hypertension. And it is crucial to consider this aspect during the management of this patient. In 2015, our research group collaborated with British, Dutch, and Spanish researchers to publish a review addressing the needs for redefining malignant hypertension. The historical definition relied solely on fundus examination, which was the only available tool in the 50s. However, with our current understanding of the systemic natures of malignant hypertension, the availability of modern diagnostic tools such as MRI and echocardiography, and because the historical term malignant no longer accurately reflects the current survival outcome of this patient, we propose a new term, multi-organ damage hypertension. In our review, we outline specific involvement criteria for each organ affected by malignant hypertension. For the kidney, we focus on acute kidney injury. In the case of the heart, we consider left ventricular hypertrophy or systolic dysfunction. For the brain, we use white matter lesion and posterior reversible encephalopathy syndrome or microbleeds. So in this proposal, hypertension mode is a condition defined by severe hypertension with involvement of 3 target organs, or the classical definition and the old school definition, severe hypertension with malignant retinopathy. In the next slide, we are talking about pathogenesis of malignant hypertension and what do we know about this pathogenesis. On the left side, the graph compares plasma renin activity in case of malignant hypertension compared to hypertensive urgency situation. Plasma renin activity is higher in situation of malignant hypertension. This finding has significant therapeutic implication. Understanding the activation of the renin-angiotensin system in malignant hypertension can guide therapeutic intervention targeting this specific pathway. We will talk about it in a couple of minutes. On the right, the figure presumes the pathogenesis of malignant hypertension. I think it's important to note that this schematic representation simplifies the complex nature of malignant hypertension. Because malignant hypertension, it is a multifactorial disorder which diverse cause and underlying pathogenic mechanism. However, this diagram allows us to identify the major player involved in the development of malignant hypertension. So the key players are RAS activation, promoted by hypovolemia, secondary to pressure-induced natriuresis. We have also increase in renal vascular resistance and microcirculatory damage. The cause of the activation of this player can be, for example, the activation of the sympathetic system, nitric oxide, vascular endothelial growth factor disorder, for example, or complement activation, and probably many more. So in the next slide, we try to answer this question: what are the different target organ injury in malignant hypertension? To reply, I want to use a lesson from the French Hama cohort Dominique presented. So next slide, the Hama cohort is a multicentric study involving 36 centers in France, including hypertension unit, renal unit, cardiology unit, and neurology unit. Dr. Romain Boulestreau, a French cardiologist from Bordeaux, is the PI of the study. This study is endorsed by the French Society of Hypertension, the French Foundation in Hypertension, and supported by the French Society of Cardiology. So the inclusion criteria in this study were very close to our hypertension mode definition I presented. Severe hypertension and malignant hypertensive retinopathy, or in the case of the absence of retinopathy, at least 3 organs involved among brain, heart, kidney, and endothelium. That means hemolysis. So in the next slide, we are reported the criteria used to define organ involvement in our study. So we use the classical definition of severe hypertensive retinopathy with papilledema and exudate. For brain involvement, MRI was a constant for the diagnosis. For heart, severe hypertrophic cardiomyopathy, and for kidney, acute kidney injury following Cadigo classification were used. For endothelium, we use hemolysis definition. So the next slide, it's a couple of results. So from 2019 to September 20. So yes, September 2022. Sorry, it's not today. So it's to September 2022. 284 patients were included in the cohort. So as you can see, the patients are very young, 48 years old. 67% were male. Body mass index was 28, and 20% of patients are from Africa. 36% smoke, and 38 were previously treated for chronic hypertension. The other either had no hypertension prior to admission or had a long history of untreated hypertension. So in the next slide, you can see that in our cohorts, 91% of patients had retinal damage and half of patients had papilledema. 63% had acute kidney injury. And it's very interesting to note that despite high creatinine level, potassium level remained low, probably due to high hyperaldosteronism, secondary to renin secretion. It is important to note that in the case of severe hypertension and acute kidney injury with low potassium level, the probability of malignant hypertension is very high. 62% of the patients had cardiac involvement with a very severe left ventricular hypertrophy. In the next slide, you can see that brain involvement was more frequent, as previously described. In the Hama cohort, all the patients had an MRI, a brain MRI examination, even if the patients were asymptomatic. And most of the patients were asymptomatic. And the lesion, so the white matter lesion concerned about 20% of patients before 60 years old in our cohort. So the FASECA score for white matter lesion assessment is a radiological score. A level above 2 indicates severe white matter lesion. This situation is found, for example, in the brain of patients with vascular dementia. Our patients are often young. The cognition of this patient could be a challenge for years to come because some of them have a brain similar to very old patients with vascular dementia. So in the next slide, it is important to note that a specific underlying cause of hypertension is more frequently identified in case of malignant hypertension compared to essential hypertension. In the Bordeaux cohort, which consists of a cardiology unit, we found that primary hypertension is present is nearly 75% of cases of malignant hypertension. However, for example, other teams, such as the nephrology unit in Madrid, observe a higher prevalence of renal disease, including glomerulopathy or renovascular hypertension, or TMA. In this context, the proportion of cases attributed to primary hypertension decreased to around 50%. So the next slide, we want to discuss about therapeutic strategy. It's a very important point. So currently, there are no specific therapeutic trials, of course, for malignant hypertension, and all the strategy proposed are primarily based on expert opinion. However, there are two main schools regarding treatment strategy. The first approach, present here in this slide, involves the use of intravenous therapy to lower blood pressure. A common consensus among experts is to proceed with a progressive reduction of blood pressure, decrease blood pressure by 20–25% during the first hour. But in the next slide, you can see that the second approach, which involves an oral strategy based on blocking the renin-angiotensin system first. In Bordeaux, our strategy involves stopping intravenous treatment and initiating a prompt blockade of the renin-angiotensin system by titrating long-acting ACE inhibitor orally. This approach is preceded by saline-free administration, infusion, to address the hypovolemia induced by malignant hypertension. It is very important, I think, because this hypovolemia itself contributes to the activation of the renin-angiotensin system. Our experience has shown that this strategy is effective and well tolerated. It is similar to the approach used for the treatment of scleroderma renal crisis, for example. In Hama cohorts, this orally first strategy is used for approximately 1/3 of patients, which may be more prevalent in Bordeaux. Additionally, the approach has recently been proposed by the guideline of the British and Irish Hypertension Society. We believe in this approach because it allows for rapid and effective intervention against one of the key mechanisms involved in microvascular damage, which is the activation of the renin-angiotensin system. Regardless of the strategy employed, I think it is crucial to promptly block the RAS, even if initial intervention was intravenous therapy. An interesting aspect of this oral strategy is its cost effectiveness, making it a good option for a country with limited resources where malignant hypertension is a significant burden. So what are the links between malignant hypertension and thrombotic microangiopathy? So this study by Timmermans, published in 2017, demonstrated the association between malignant hypertension and atypical hemolytic uremic syndrome. The study aimed to investigate pathogenic variant of complement regulatory protein in 9 patients who received a kidney graft for malignant hypertension. Interestingly, the researchers discovered pathogenic variant in 6 patients, leading to a reclassification of this patient from malignant hypertension to atypical hemolytic uremic syndrome. Importantly, it was observed that this patient frequently experienced relapse of thrombotic microangiopathy after transplantation. This finding highlights the need to consider atypical hemolytic uremic syndrome, particularly in the context of kidney transplantation, as it significantly impacts the management of this patient. For instance, it may necessitate the use of eculizumab during kidney transplantation or in case of acute vascular lesion or severe hypertension after transplantation. So the next slide shows that another way to demonstrate the association between malignant hypertension and TMA is by examining the frequency of malignant hypertension among patients with, for example, atypical hemolytic uremic syndrome. Our Spanish colleague have employed this approach and found a significant prevalence of malignant hypertension in their cohort of atypical hemolytic uremic syndrome. By simply performing a fundoscopic examination, they identified malignant hypertension is nearly 40% of these patients. So the next slide shows that having malignant hypertension in the context of atypical hemolytic uremic syndrome has significant implications. In the French cohort of atypical hemolytic uremic syndrome, it has been demonstrated that the presence of malignant hypertension is associated with a worse renal prognosis, even when treated with eculizumab. Additionally, it is interesting to note that malignant hypertension is more frequently observed in men and is associated with a higher incidence of cerebral vascular involvement. Malignant hypertension is rarely a systemic disease. The next slide shows a figure which illustrates the various etiology of malignant hypertension along with the probability of associated TMA. The probability is higher in case of course, atypical hemolytic uremic syndrome. We often observe TMA in other conditions as well, including drug-induced malignant hypertension or malignant hypertension secondary to autoimmune disorder, for example. To finish, so ex vivo C5b9 formation has been explored as a potential tool to guide treatment decision, particularly in the context of malignant hypertension and the use of complement inhibition therapy such as eculizumab. The method involves a serum sample from malignant hypertension patient and depositing the sample in vitro onto human endothelial cell from skin. The aim is to evaluate the serum ability to form the membrane attack complex on the surface of its cell. The rationale behind this strategy is that in malignant hypertension, particularly in case associated with hemolysis, the activation of the complement system can play a significant role. By assessing the ex vivo C5b9 formation, we can gain insight into the patient complement activity and the potential benefit of using complement inhibitor, such as eculizumab. This method requires further investigation. So in the next slide, you can see my take-home message. about a patient or when you suspect a patient with malignant hypertension. The first step is to, of course, confirm the diagnosis. Fundus examination is a useful tool, but please do not forget to assess all the organs involved in the case of malignant hypertension. The second step is to assess severity. And severity is, of course, for kidney, of course, for heart, but please for brain, because we found very severe vascular lesion in the brain of this patient. So I think systematic MRI for patients with malignant hypertension could be very useful. The treatment strategy is, of course, target blood pressure. You can choose your school, oral RAS blockage first or intravenous drug therapy first. But the main thing I think you have to do is to start promptly a blockage of the renin-angiotensin system. After that, you have to try to identify the cause, because we have seen that more than 50% of patients has an underlying cause behind malignant hypertension. So of course, TMA, glomerulopathy, or other cause of secondary hypertension should be assessed. And the last thing is patient follow-up. We try to follow this patient every month in the first 6 months after an acute phase of malignant hypertension. And we try to avoid to have a patient without follow-up during the first years. So I think it's very important to follow this patient because of the risk of the relapse and to assess cognitive function. Thank you very much for your attention.
Thank you. I have a little question. I'm a young doctor myself. I still have to do my rotation in the ER. So let's imagine there's a patient coming, 50 years old, a man who has severe hypertension, 240 to 140 BP, and his general practitioner sends him. So in the ER, the patient doesn't have any symptoms. He feels completely fine. He doesn't know why he's here. So how should we proceed with this patient? What workup do we need to do in the ER? What can wait?
Yes. So I think it's a very common situation in emergency room, of course. So the main thing is to exclude hypertensive emergency. That means you have to exclude congestive heart failure. You have to exclude aortic dissection. You have to exclude, of course, malignant hypertension. I think a good way to process is to, after clinical evaluation, after the look after stroke, for example, or focal neurologic symptoms, you should dose kidney function. You should dose potassium level. You should assess hemolysis with haptoglobin or LDH level. And please do EKG, because it's very easy to find a very big cardiomyopathy, hypertrophic, left ventricular hypertrophy in the EKG. In our experience, malignant hypertensive patient has a very severe left ventricular hypertrophy. And the useful thing in the EKG is the air wave in AVL. When this wave is more than 1 centimeter, it's a very good sign that the patient has a very severe left ventricular hypertrophy. And in the case of very high blood pressure level, it could be a malignant hypertension.
Thank you. Maybe just one other question from me. So should every patient with malignant hypertension be screened for secondary causes of hypertension? Just to have a look at the renin and aldosterone, for example?
Yeah. Yes. All patients with malignant hypertension, I think, require exploration for a secondary cause. So at the acute phase of malignant hypertension management, the main question is there hemolysis to exclude TMA? we should to exclude systemic disorder like sclerodermia, like lupus or something like that. In the case of hemolysis or systemic autoimmune disorder, for example, you have to assess complement, so complement evaluation. And if there is a big hemolysis, you have to I think you should process to genetic assessment of the complement. So at the acute phase, we do a renal artery evaluation during the acute phase with using a Doppler, for example, and we do abdominal CT to exclude large adrenal lesion, for example. And to reply to your question about the exploration of, for example, primary hyperaldosteronism. So we try to explore this disease 6 months or 1 year after the acute phase, because you need to stop RAS ACE medication. So we try to be sure that the patient is very stable, very chronic. And yes, I think this patient needs to have a renin and aldosterone evaluation, but we try to do it a couple of months, 6 months or 1 year after the acute phase.
Thank you, Sebastien. Can I ask a question too? I'd like to thank you for this great presentation, a synthetic overview of a complex situation. I think one of the major inputs of the Bordeaux team, which has worked quite a lot on malignant hypertension, is this provocative view of reintroducing ACE inhibitors at the acute phase. As a nephrologist, I've usually learned to stop these treatments when you have acute kidney injury. And I must admit, I'm quite convinced with this strategy, with all the things I've seen from you and from your team, and Romain Boulestro you talked about, because you have interesting results. And you didn't say that, but I'd like you to comment on the fact that this treatment does not give deleterious results on the creatinine evaluation and on the potassium, because this is the main thing we all worry about in this context.
Yeah, so in the case of malignant hypertension, most of the time the potassium level is low, and because of the very high hyperaldosteronism secondary to renin secretion. In fact, in our experience, we never have any problem with an hyperkalemia when we titrate ACE inhibitor, for example. And I think we have to learn about renal crisis sclerodermia management for this patient. When we see the very severe vascular lesion, for example, in the brain, I think our mission is to try to avoid the major vascular lesion. That's why if the patient needs to have dialysis, for example, because we initiate ACE inhibitor at a high dose, I think it's not a problem because if the patient is in dialysis, he is alive. And I think it's the main things we have to do to protect his vascular involvement. And I think the best way to date to do it is to use ACE inhibitor. But in our experience from Bordeaux, to be honest, we have very, very few cases of patients who require dialysis because of ACE inhibitor introduction. Very, very few.
You gave us the recipe, the protocol for the augmentation of the dose of I think
yes,
in your thing. Of course, this has to be in a unit used to this and who can follow the patient very closely. What's the recipe for the saline infusion? How much do you give in a normal patient?
Yes, so we try to 50. I think that depends of the patient, and it's 1 liter or 100 milliliters saline infusion before initiating ACE inhibitor. Okay. And so, for example, yes, 500 millimeters in 1 hour, and just after that, we can start our titration. And it's a very, very quick titration. In our algorithm, we use ramipril or perindopril, but we start at low dose and we give double dose. We start at low dose, for example, ramipril 2.5 milligram, and 6 hours after we give 5, 6 hours after we give 10, and 6 hours after we give 10 again to have 20 milligram of ramipril, for example, per day.
Okay,
so
great.
It's very quick.
I have another. I think this is really important, honestly. I have another question. Who requires kidney biopsy in this context, and how quickly should it be performed?
Yes. So in the case of malignant hypertension, of course, we have the time to think about biopsy, because at the acute phase biopsy, we can't do kidney biopsy because of the very high blood pressure. So I think it may be done promptly when kidney biopsy, when, for example, there is a severe acute kidney injury, such in case of patient require dialysis, or when the kidney injury progresses rapidly. The second thing is when a diagnosis of TMA is strongly suspected, because kidney biopsy can be useful. And when the kidney biopsy can influence treatment decision, for example, in case of autoimmune disorder. In the other case, we allow for 3 weeks to monitor the decrease in proteinuria. And if the proteinuria persists, the evaluation of the kidney biopsy is exactly the same, like a patient who has a glomerular pathology. So we can think about kidney biopsy during a couple of days to the time to decrease blood pressure, and there is a few indications to proceed promptly. And in the other case, kidney biopsy is done at month 2 or month 3 after acute phase.
Okay. Last, it's not really a question, it's more a comment. As you said, in the published cohorts, they are either on the cardiology side or on the nephrology side, which means when you read the literature, you have a very different view of what malignant hypertension is. And I think this is very important for us when we take care of these patients to not be too biased in our vision of what we can have in terms of consequence, in terms of cause and of consequence. And one of the messages you gave as an answer to Sarah is very important. Is these patients should have a workup for secondary hypertension. And many of the units in which we take care for malignant hypertension, not particularly specialized in the workup of secondary hypertension. So I think one of your take-home messages is, of course, send them to your colleagues who deal with hypertension if you do not have a cause in the first workup. And
yes, absolutely. All patients need to have a secondary hypertension research.
So thanks also from my part, and it's really fascinating to see that something's going on in a field of hypertension research, which has been kind of neglected for decades, I guess. And when we look into the ESC guidelines, there's few lines actually on hypertension emergencies. So my first question would be with regard to nomenclature again. So the technical terms we learned at medical school were actually emergency and urgency when it comes to hypertension, and then this very old term, as you explained to us, of this malignant hypertension. In Germany, at least, I never saw an eye doctor coming to the emergency room to examine the eyes and to give us any information on retinal hemorrhage or cotton wool spots. This information is actually not available for clinicians at the ER. But when we will redefine these terms, will we still require the term of urgency? And the second question would be then this hypertension MOD that you introduced and the emergency hypertensive crisis. Are these mutually exclusive terms? So does one patient either have a hypertension emergency or this hypertension MOD, or can he or she has both terms at the same time?
Yes, thank you for this question, because the literature about the name of the hypertensive crisis is very complex, and urgency and emergency, of course, are come from English literature. And so I'm not sure if this term is very useful in clinical practice, but hypertensive urgency is a condition it's only a condition with a patient has a severe hypertension. That means very high blood pressure level, probably higher than 180. But a patient with hypertensive urgency does not need to have immediate or urgent management or urgent treatment. So, for example, it's a patient who come in here with an epistaxis and high blood pressure because maybe we don't know exactly why, but we are not sure he has a real very high blood pressure, but we are sure that we don't need to introduce an emergency treatment for this patient. So the main point is to be sure that the patient does not have an hypertensive emergency. And hypertensive emergency is a second condition. In the case of patients who needs to have an emergency treatment, it's the case for malignant hypertension, of course. So malignant hypertension is one cause of hypertensive emergency, or it's exactly the same in the case of aortic dissection. Aortic dissection is not a malignant hypertension, but aortic dissection needs to be treated by antihypertensive agents promptly. So hypertensive emergency and hypertensive urgency are two different things, but hypertensive emergency include a lot of things: malignant hypertension, aortic dissection, congestive heart failure, and hypertension mode, multi-organ damage.
And I have a second question on your definition of hypertension MOD. So you include a couple of terms which are rather specific to acute emergencies like acute kidney injury, angiopathy, but there are the cardiac terms like hypertrophy of the left ventricle, which is due to a rather long-standing hypertension, because people will not get hypertrophy within a few hours or days.
It's very interesting because in our experience from Bordeaux, because the hypertensive unit in Bordeaux is in the cardiologic hospital, and so we are a very big interest in heart involvement in the case of malignant hypertension. And you said that left ventricular hypertrophy is a chronic condition. You're right in the case of chronic hypertension, but in the case of malignant hypertension, we saw that a patient has a very big left ventricular hypertrophy, a very severe, but in a couple of weeks or months after blood pressure level decrease, the left ventricular hypertrophy decrease and remain mostly or close to normal value. So our hypothesis in the case of malignant hypertension, the left ventricular hypertrophy is not really every time a chronic condition. It's sometimes an acute condition. It's very strange, it's very new, but in our experience, we think that.
So there might be some kind of myocardial edema playing a part, which might explain that the ventricle gets thicker, and then within weeks of treatment, it gets thinner, because there must be an underlying reason for this rapid changes that you observed.
Yeah, no, we don't. No, so we did heart MRI to try to explain the cause of this hypertrophy. We didn't find any fibrosis in MRI, so it's a new indication for acute condition. And no, I don't think it's edema. I think because the post-charge is very, very, very high, because the blood pressure is very high, the heart muscle increase. But we don't find edema. We don't find edema.
That's highly interesting, really, because I was not aware of this.
No, I'm not a cardiologist, so my knowledge about this specific involvement is not very, very big. But in my understanding, it's not edema.
So another issue would be, when do you do complement examinations? And if you do so, I understood you do genetic testing. You don't measure proteins in the plasma, but you go directly to genetic profiling of these people.
No, we do both. Of course, we do protein evaluation in plasma, but in the case of malignant hypertension with TMA or biological TMA, we every time do both. That means protein level examination, CFH, complement factor H antibody assessment, and genetic test.
And this is covered in France by the insurances, because sometimes it's a little bit difficult here in Germany, not always, but it's not that easy actually to get genetic testing here in Germany.
So no, it's not very easy to have the result quickly. It takes a couple of weeks or sometimes a couple of months. But I think it's very important, particularly in the case of future kidney transplantation, because if this patient has a complement disorder, I think the graft team, the kidney transplantation team, needs to know this issue. So we try to never forget to test genetic complement.
So my last but one question would be, in your cohort, the number of patients with primary hyperaldosteronism was about 6%. This sounds rather low, given this low potassium values that you found, but I understood that you said, well, the majority of these people might have secondary rather than primary hyperaldosteronism. Surely the definition of hyperaldo is also under discussion, and we talked some months ago with Professor Vander from Australia, who nearly considers everybody to have hyperaldo. So maybe this 6% might be higher with an other definition, if this definition will change in the foreseeable future. What are your ideas on that?
So I think primary hyperaldosteronism, it's not a very common condition in malignant hypertension, because if you have a look in resistant hypertensive cohort or as resistant hypertensive patient, the prevalence of PA is very, very higher. So I don't know, and I'm not sure. I think nobody knows really the precise mechanism linking PA and malignant hypertension in this case. But of course, we have to screen it because it's a common secondary cause. But in the case of malignant hypertension, in our experience, in the literature, it's not very common, and it's not the first cause. That's why we can wait a couple of months to explore it.
Okay. Yeah. And so my last question before switching the mic back to Sarah, your ideas on treatment are so fascinating, and surely they will make life easier at the ER, particularly as I guess the majority of us is not really familiar with IV antihypertensives. But are there patients in whom you would still go for IV treatment? So say if the blood pressure does not go down within some hours or something, do you have some, ideas or some rules when you still use IV treatment in these patients?
Yeah. So, of course, our approach is the main of this communication is to explain that, in our opinion, the best thing to do urgently is to block renin-angiotensin system. But of course, we don't want to have a patient with very high blood pressure all over the night and a couple of days. So I think the best way is to avoid initiate intravenous drugs before we have a very high dose, that means double dose of ACE inhibitor. Why? Because if your blood pressure going down with your intravenous medication, we will not be able to continue to increase your ACE inhibition titration. So I think the first step is to introduce ACE inhibitor to increase the posology. And when the posology is high, if the patient remains very high, if the blood pressure of the patient remains very high, of course, you can add intravenous therapy, intravenous drug infusion. We are not, we are very open, of course, of intravenous therapy, but in the second way.
So I'd like to know a little bit more about Bordeaux. We're doing a little Tour de France Académique, as you know. So could you tell us more about the city you live in?
Oh, yeah. No, yes. So Bordeaux is a very great city in the southwest of France. And yes, I wanted to provide you 3 highlights from Bordeaux. The first one is the cannelé. So the cannelé is a small cake with a soft inside and a sweet, crunchy outside. It's made with rum and vanilla, and it's amazing. And in Bordeaux, you should try it with a coffee. So coffee and cannelé, it's very typical of coffee break in Bordeaux. So the second, there's the Cité du Vin, City of Wine. This is a big museum all about wine. You can learn about the history of wine, taste different wine, and even see the whole city from the top of the building. Because as you know, Bordeaux is the capital of the wine all over the world. Finally, we have the Bassin d'Arcachon. Bassin d'Arcachon, this is a beautiful bay, not very far from Bordeaux. And it's famous for its oyster and for having the tallest sand dune in Europe, the Dune du Pilat. It's a great place for a day trip to enjoy the nature and try some seafood close to Bordeaux. So there is my 3 tips for visiting Bordeaux. Try a cannelé, visit the Cité du Vin, and take a trip to the Bassin d'Arcachon.
Thank you so much. Now I know where to go.
Thank you very much.
Thanks again from our part. And we will stay 1 more week in Bordeaux, and we will come back next week. Surely you made us interested both in novel approaches in hypertension and also in visiting Bordeaux in the upcoming month. Thanks so much. Have a nice weekend and hopefully meet you soon again. Thank you, Sebastien.
Thank you very much.